My name is DJ Madsen, and I own M&M Health Solutions. We are a wellness company that focuses on direct-to-consumer lab work as well as hormone replacement therapies, and we offer dietitian services to providers. Right now, I primarily focus on male and female hormonal health, and I'm a translational pharmacology student.
I'm Gail Jackson. I'm a physician, a gynecologist, and I've transitioned my practice into menopause medicine, specializing in bioidentical hormone balancing, specifically using pellets, vaginal rejuvenation, weight loss, everything a woman needs to know to stay forever fabulous.
I'm Alexandra Dubinska. I'm a board-certified OBGYN and urogynecologist, pelvic reconstructive surgeon. I also specialize in sexual medicine and menopausal care. I work in Beverly Hills, California, and I make sure that I take care from women from all-day pelvic health, emotional health in some ways, and help them optimize the kind of second part of their life.
I'm Dr. Joshua Gonzalez. I'm a board-certified urologist and sexual health expert. I did a fellowship in sexual medicine, so I am lucky to be able to treat all genders who are having sexual health issues. A lot of that focuses on hormone health, testosterone replacement, menopause hormone therapy. So I see patients from 18 to 90 who have sexual health issues.
We started hormone balancing in our office in 2008, and we were the lonely voice. And many colleagues discouraged us. They condemned us. But now, fortunately, there's a cacophony of voices everywhere, stars all over the screen who refuse to accept aging as the normal and insist on being their best and fabulous self, and they are going to seek the solutions. They seek the solutions that we offer, the folks here that we offer. They want healthy solutions, and they are going for it, and they believe in it. And so I think it is the topic. It's the now topic, and I'm excited about it. Finally.
Yeah, and I think you're right. It's the WHI study was unfortunate study that happened that put a lot of fear in women, and I encounter so many patients every day who come in and says, no estrogen, no hormones, I want to be hormone free, despite all us living with hormones majority of our life. And that study was poorly done. Now, finally, we go around it, we get more data, that's better data. And women start slowly learn what's right and how important hormones for you, even like after menopause. So I think now we can see how minds being opened up a little bit more so we can actually live a better life.
Yeah, because when Halle Berry says, I'm getting balanced, when Oprah Winfrey and Michelle Obama, the ladies listen.
Yeah.
I think one of the biggest issues I'm seeing on my end of things is not everybody has a well-educated provider or somebody that's gone above and beyond to extend their endocrinology education. So in some cases, as much as I love HRT and I promote it and I know how it can change lives, we see so many women that are negatively affected because they don't get paired with a proper provider. And then it becomes a disaster, and it kind of perpetuates that fear of HRT just because they were not with an educated provider. Yeah,
I would say some of the biggest naysayers about HRT come from the medical community. So, as physicians, like we go through this long medical education system, some from gynecology, I come from urology. We never got talked to about sex. We never got talked to about hormone health. And it's such an important part of how we exist every single day. And to tell someone that it's natural to, enter menopause and to sort of live miserably for the last 30 years of their life because that's what's supposed to happen is just ridiculous. Like our bodies evolutionarily, we're not meant to live to 90, right? And certainly if you have a low functioning thyroid, no one would ever bat an eye to replace that and give you thyroid hormone. Or if your pancreas stops working, we give you insulin, right? These are all hormones. So why is it any different when we're talking about testosterone, estrogen, progesterone? Just because they're sex steroid hormones, they get this sort of bad rap. And it's really unfortunate.
Well, that's an easy question because we were not educated to teach it.
Yeah.
I've been board certified a long time and at Cedars-Sinai, and the grand rounds still are not about menopause. It's just not seen as something important to have a topic of discussion. So that's the main reason, because doctors don't know. And I think a funny little saying is when doctors are not up on it, they're down on it. And Josh and I were having a chat because we both do pellets. And I said, listen, if any of your ladies bleed, send them to me. Because what happens is when we send our patients that may have complications, or if I have my ladies go outside of my practice to just get a pap smear, they're probably going to interface with a physician that's going to really discourage them from hormone balancing. Thankfully, my ladies speak up and they said, okay, I feel amazing. I'm doing all these wonderful things. You tell me to to stop them. What do you have to offer me? And so a few physicians get a little insulted, but that ends the conversation because they're feeling good. They're educated. They've done the studies. Why shouldn't they have the option to do that? But basically, most physicians are just not trained. We weren't trained, so we have to want it. And I also tell my ladies, don't criticize your physician for not doing it because I'm not a robotic surgeon. So there's certain things that we get interested in. Fortunately for my patients, my menopause was horrific. So I always stay on top because mine was horrific. So I found the solutions for me. And like I tell them, I'm that girlfriend who shares all her secrets. I tell it all.
I think this is a very unique dynamic right here as well, because what we see is women are kind of left in this gray area of HRT where the endocrinologists are not going to mess with sex hormone replacement therapy, but not all gynecologists have gone and done the extended education to work on the endocrine system. Right. So we need primary care physicians that are willing to either extend their education or refer out, which is a big one, and then finding the right providers that are kind of that unique mesh. But I feel like women in a lot of cases, we're just left out in terms of hormones.
Yeah, I mean, I think when people come to see me, they've often seen 5, 10 other providers, right? Been told you can't get hormones. Hormones are going to kill you. Hormones are going to give you cancer. All these, pieces of misinformation, and it ends up doing a lot of harm because it's really out of ignorance, right? Like I also tell them when they tell me these stories, listen, it's not really your doctor's fault because I went through the same medical education system. I didn't get this education until my fellowship because I chose a fellowship in this and I'm interested in this. So I learned specifically about this. But if you just kind of go through the regular path, you don't have that education. I think what we need to help our colleagues do a better job of is if you don't know, don't give them false information, right? Like don't scare people just because you are ignorant on the topic yourself.
Yeah, absolutely. And also it takes time to kind of fix the damage that was done, not with a bad intention by other doctors, but when women come in and they don't know, you can just say like, okay, everything you learned is not true. Go ahead and take the hormones. You kind of need to slowly, very gently give them more information and give them space to come to the conclusion and realization themselves. But it also takes valuable time and they feel miserable.
So in all reality, I mean, we're abusing these hormones. They're being abused entirely. But in a postmenopausal state or even peri, when someone's on like a full HRT protocol where we don't have to worry about suppression of the HPO axis, it's ideal. When it becomes a problem is when we have a 21-year-old bikini athlete that has fertility needs. We need to prioritize ovulatory cycles, and they decide they want to take an Anavar cycle. Because in our realm, people say, well, Anavar is a female drug. It's a female steroid. Not realizing there's still going to be suppression, that even though it's lowering your testosterone levels, it's still a risk for virilization. I don't think enough females in the performance-enhancing realm understand the virilization risks that can occur. But the actual health risks and repercussions are very similar with what we're going to see with our male bodybuilders as well. And it's funny because I'm here and I'm like, every woman needs TRT. If you're deficient, let's do it. I myself am not a candidate. I had virilization issues on low-dose DHEA. I'm very sensitive to androgens, and I don't think there's enough education out there right now to really help guide women to do it safely. And I really just don't think they understand the long-term consequences realistically. You have coaches in my industry that are like, well, I can make money if I create a good transformation. If you throw enough drugs at anybody and they lift weights, it's going to be a good transformation. But that comes down to ethical guidelines and coaching practices as well.
I have very little familiarity
Yes.
with that world, so I'm
Think about the patients that
learning
you
from
get.
you.
Let's see the patients that maybe wanted testosterone, their primary care physician said no, and their husband said, I'm on test. I'm on 200 megs a week. You're about half my size. I'll give you 100. And then you get that patient and her levels are 600 nanograms per deciliter.
Yeah.
That's very similar to what I deal with on a regular basis. And trying to convince women they don't need to run testosterone cycles like their male counterparts is a whole other argument. If they can find a way to put it in their body, they will abuse it. Disagree.
Well, it's not everyone is the same and every situation is different. Some people go in premature menopause and you do need to replace the hormones in order to continue live your life and be healthy. There are also other conditions that can affect your ability to produce the hormones. Talking about oral contraception pills. What they do, they increase the amount of sex hormone binding globulin, a special protein in the liver that will make your own hormones inactive. And one of the first areas where we see that deficiency is actually genital area. Women, even in their 20s or 30s, who've been taking oral contraception pills for many years, might start experiencing vaginal dryness, pain, urinary frequency. And what we do, we replace topically these hormones that have been missing. Ideally to stop a contraception, but not everyone can do that safely. So at least having some replacement topically to remove those symptoms. So yes, there is obviously cases that requires hormone replacement therapy, and it doesn't depend only on age.
I believe I know it's truly safer because the synthetic hormones just suppress symptoms. And those are the ones that were used in the WHI study. And so we saw the increase of breast cancer. I mean, those were archaic hormones. No one uses those, but they're thought to suppress symptoms, whereas the bioidentical hormones replicate the hormones that are in the body. So when the body receives them, it acknowledges them and experiences them as their own. So there is a difference, absolutely.
Yeah, I think the big controversy about bioidentical is the way that they are used in marketing, right? So women are told, I have, or I can give you bioidentical hormones, but like anything else you get outside of this office is like not bioidentical, when oftentimes they're using that term to say compounded, and they're probably selling those compounded medications out of their office. So people get confused, right? They think if they're getting, vaginal estradiol, that's not bioidentical because they pick it up at their CVS, right?
And it
is bioidentical.
Absolutely.
All of the FDA-approved formulations of testosterone, estradiol, progesterone, if that's what they're actually called and don't have other little names attached to them, are bioidentical.
And progesterone.
Yeah.
I think that even the term synthetic might be misunderstood in some capacity, like especially with like our testosterone injections. I don't think people understand that once it's in your body, like obviously it's synthetic, of course, but we have those esters, but once they're cleaved in the bloodstream, it's your own testosterone in your body acting as testosterone. And obviously there would be differences versus like you work with men and clomiphene, how that's going to impact free testosterone versus what we see with exogenous hormones. But I think a lot of it is how it's pitched by a provider. And again, marketing practice to practice to make sure you buy your hormones here and not anywhere else.
That's right. Yeah, I think also like when we're referring to synthetic, especially as it relates to women, I think birth control pills, things like Premarin, right? Like you said, those were what were studied in the WHI. Those have been associated with blood clots. Those have been associated with certain increased risk of cancer. But when you are using bioidentical hormones in whatever form they're in, these treatments are very safe.
I feel it's definitely underrated.
Yeah.
It is life-changing for women, and I see it daily in my practice because women go to their primary care and they're in their mid-40s, especially for women in their 40s, because they're like the energy, focus, mood, brain fog, libido. Like, I love my amazing husband. I've been with him forever, but I just lost that love and feeling. I just don't want him. And so when we draw the testosterone level, usually their estrogen's fine, they're ovulating, they're still having cycles. perhaps not ovulating, but when they realize their testosterone is low, oh my God, it's life-changing because they feel someone is finally listening to them and not just saying, oh, your thyroid test is fine, go do more self-care, work out more. And then when we give them some testosterone, it is really life-changing. And I really love to see that change.
And also, it's interesting how when you check the testosterone and you get the lab report, they're showing you that the normal testosterone is from like 2 to 30.
Right.
And like, if anyone would have a testosterone of 2, they're going to feel miserable.
Or 30.
But, right. But people look at that and like, okay, you okay. Nothing wrong with your testosterone.
Yeah. I mean, I think one thing that a lot of people don't understand is that women at any given time have more testosterone in their body than they do estrogen. They like the units on the normal ranges are completely different. So even though the number values that we look at for estrogen are tenfold more than what we look at for testosterone, it's a matter of units. Yeah. And so they actually have more circulating testosterone in their bodies than they do estrogen. So the idea that it's a male hormone is very outdated, but I still see it in patients coming to see me where they may have been offered hormone replacement therapy and it doesn't include testosterone, and that's the missing piece for them, right? Like a lot of their hot flashes are fixed, they're sleeping better, but like you said, their sex drive still isn't there. They may have trouble making gains at the gym despite working out with their trainer and eating healthy. And so that's sort of the missing piece that unfortunately gets left out a lot.
I think that what needs to be reinforced is what we always see, what we see here, is I use the term optimal levels. Because when the patient, and I said, we simply use your lab so you can use your insurance and get these results. But these are reference range. We don't know. So if you want your levels to be someone in their mid-50s, that's not our goal. These are our optimal levels. So our patients learn the term optimum levels versus the reference range. Because very often they'll call you and they're like, or they'll see the optimum level in range, and they're like, oh my God, my internist called me and said my testosterone is sky high. What am I going to do? Like, no, here are your levels. Right. And so I think it's a lot of education. That's something I always have to teach you guys too. Yeah. I
think it's damaging also to tell somebody that they're normal when they don't feel that way.
Exactly.
Right. So, and we run into this a lot. Even with my male patients, they'll have hypogonadal symptoms. Their testosterone happens to fall in the normal range. Again, these ranges are very wide, 300 to 1,000, say, and they're like 305. And their primary care provider sees it, says, oh, you're normal. And they're like, but I'm saying all of these things to you. I don't feel normal. Something is wrong. And so I agree with you. That's what I do with my patients. I say, we're not about making you normal. We're about optimizing your hormone health.
I think optimization is like, we're done. I think optimization is like the key factor here. We want to look at functional ranges, especially in terms of thyroid function as well. But on the flip side, I do blood work analysis through one of my companies. That's where I see testosterone being used as a Band-Aid for men and women. A Band-Aid that I like, a Band-Aid that I support, and a Band-Aid that I encourage. But you can mask so many symptoms and other deficiencies. So many women are like, oh yeah, you're suboptimal. Their provider has learned that word. They're really excited. Here's some testosterone. But we're not checking vitamin D levels. We're not talking about protein intake, strength training. We're not looking at the combined oral contraceptive and your skyrocketed SHBG that you've been on for 10 years when you actually have PCOS and you're not a good candidate. Yeah. There's so many factors to explore, especially with testosterone. And again, I'm all about using it. If it improves your quality of life, we're going to do it. But even when we have people that maybe are on like SSRIs, there's secondary factors that are relaying to those symptoms, or maybe even just their doctor pulls TSH, but they didn't pull free T3 levels. Those are things that can, again, be suboptimal ranges, or do we have suboptimal thyroid function? So that's one of the things I see overlooked a lot, even though I love testosterone treatments, and the libido that women get from TRT is incredible, puts everybody back on track even after 25 years of marriage. It absolutely is. I can say that for sure. But there are socioeconomic factors that need to be taken into account. I had mentioned just earlier about like PCOS disguising symptoms as a teen. Well, not everybody's going to have access to a specialist. Not everybody is going to have a family or the means to take myo-inositol and watch their food intake and change lifestyles. That's unfortunately a viable option for many young women. I hate it. I dislike it. I do my best to educate against it. But unfortunately, we have to have those alternatives available. It's just what it is. But there are other versions of birth control. And I think that's something why it's so good to see a specialist where that you can speak to find out what options there are, because it's not just a conventional COC anymore. And I know that's what I was put on. She's having heavy cycles at 12, COC for her. I was one
headaches.
of those girls.
Yeah, migraines.
Yeah. But the also issue is that it's not only about oral contraception pills. There is no really good birth control method out there, because even IUD, when women have an IUD and you check the hormonal levels, quite frequently I find them suppressed.
And they're only supposed to be localized, but the blood work says otherwise.
But again, it's also going back to the training when doctors go through their residency fellowships. There's so much unknown still that we're just not educated about it. So it's not the patient's fault. It's not the doctor's fault. I think we just all need to learn more and get more data and provide appropriate information and counseling for women who starts on birth control.
Yeah, I think it's about the patient education, right? Like, we as providers need to know more, have more options. But like, I think the real tragedy with birth control is when you see a young woman who has all the side effects of birth control because of the skyrocketing SHBG and the low testosterone and suppression of estrogen and progesterone, right? They basically present as a menopausal patient, right? And no one ever had the conversation with them about this. It was like reflexively they were put on it as teenagers, and they just stayed on it because they don't want to get pregnant. And I always tell them, listen, we don't want you to have an unwanted pregnancy either, but we might have to find another contraceptive solution for you, because I think this is really causing you harm. This is really the cause of your symptoms. But I think having educated providers talk to them before putting them on these treatments so that they can make an educated decision as to whether or not they want to be on them in the first place. I think it's important.
Perimenopause is my world. So.
Well, this applies to you too, because remember, there's a lot of providers out there that say, well, you don't need HRT, we'll put you on birth control.
Oh my God.
Yeah, I do have to take them off birth control, but I don't have that. Yeah.
Maybe not only a pill issue.
This is actually, we have clinical data on this now where we look at hormone replacement therapies and how it can influence levels of attraction. But I think one of the things that we don't take into account with these is when you do have balanced hormones, it changes everything. And sometimes your spouse can suck. And I think people forget that. And I think that's frequently overlooked.
So if you're, let's say I'm a young woman going on birth control or going off of it, it does impact, because I know this is a bit of a controversy, like on the type of man you're attracted to or the type of person you're attracted to. Does it affect that? Really? Do we have data, or is it more like what you said?
There has been research done on, and this is not something that I'm really familiar with because I've never actually read. I'm sure they're available on PubMed. But it's supposedly, yes, it's supposed to influence your level of attraction and potentially what type of masculinity you are drawn to based on hormone levels. But I'm not real well versed in it.
Yeah, I don't know.
Have y'all heard about the data that came? I think there's we only like one or two studies on it.
Yeah.
And what is subjective? That's a...
Right. Yeah. I mean, I could definitely see like the effects of the birth control pill on hormones and the elevation in SHBG changing how you feel sexually in general. I'm just not aware of like how it specifically changes who you're attracted to.
Right. I'm going to look it up.
I know.
Well, I think one of the memorable experiences, and unfortunately I see it way too common, when women go through the menopause, get divorced, finally rebuilding her life, meeting her Prince Charming, everything going well, and they're trying to have sex, but they can't. And it brings a lot of frustration and stress to relationship, and they come and see me. And now women learn that, she would have not been on the hormones. Her genital area has changed. Her vagina got smaller and shorter, and it's very dry and painful. And her clitoral hood has been closed. She can't really experience normal orgasm. And it takes time to undo all that harm that was happened throughout the years. But when you're done with the journey, when you put them on the right hormones, topical, systemic, when you remove the adhesions, and they can finally go and enjoy and have the best sex of their life, I think it's very rewarding to me as a provider.
I have a story. So Sandra is a CEO of a major corporation with offices in various cities, and she called me because in her meeting, she was having bouts of forgetfulness. She couldn't keep a train of thought, and then she would have a wave of heat. So she just chatted with me about that, and then one night she called me and she says, "Okay, I'm walking out of my house into my yard, and I'm walking into my swimming pool." The problem was it was an October night and her pool was not heated. So she was so desperate with her hot flashes and her symptoms that she felt her only option was to walk into a frigid pool for help. So that finally she called me. It takes something like that for someone to finally call you. So when she called, she came in, we got her labs, had a conversation with her, and realized she had a lot more symptoms associated with hormone imbalance than those few that she shared. We got her balanced. She's back.
Yeah, you guys got it.
Okay, well, I will call this the story of the woman who had a pussy transplant. So I had a patient who was sort of in perimenopause, had been on birth control for 15 plus years, was married, struggling in the marriage. They were going to couples counseling, very close to divorce. A big part of that was because they hadn't had sex in years. And they weren't having sex because she was experiencing a lot of pain. Some of the stuff that you just shared, right? Dryness, pain with insertion. And she just said, "I can't do this anymore." And he became resentful and they started having problems. So she came to me. It took a few months, got her feeling good again, ready to have sex again. And then they finally get together and have sex. And he said, "I almost feel bad." And she's like, "What do you mean?" He's like, her husband said, "It feels like you got a pussy transplant and then I'm having sex with somebody else." And she came in literally in tears saying the words pussy transplant. And I was both crying and so excited for her. But I think that those stories is what makes what we do worth it, right? Like when you really see it save a marriage, when you really see someone go from like, having suicidal thoughts because they're so miserable, to becoming a completely different person. And they'll say to you, "I feel like myself again." You know what I mean? And it's really, I think, a really special thing to be a part of.
I mean, there's always great, rewarding ones. Those are obviously the best to know that you're not only making a difference in someone's life, but everyone around them as well. But I'll go on the opposite end of the spectrum. In one of my disasters, I had a consultation. This was just a few months ago with a woman, and then it was a dual thing because her husband got on a call with me the next day. She had been overdosed by a provider on injectables, and her testosterone, it was through a LabCorp, so there's a cap, and it came in at over 1,500 nanograms per deciliter. Estradiol was sitting at 4 something. So she said, "Well, I'm growing whiskers and my voice keeps cracking. I don't know what's going on. My clitoris is definitely enlarged, but hey, it feels good. It's enlarged." So we went on this call, talked about more appropriate levels. And she said, "Yeah, my husband's been having weird side effects too. We're seeing the same provider." They did not explain transfer risk time for her vaginal estradiol. And his levels on no hormone treatments, I believe it came back at like 77 picograms for his estradiol, and was developing gynecomastia. He said, "My nipples are itching like crazy. My areolas look like a woman's. I'm not sure what's going on." And I said, "Is your wife on any other hormone treatments as well from this provider?" She gave her husband gynecomastia.
Wow.
That's man breasts.
Yeah.
Gynecomastia, man breasts.
That's crazy.
But actually, it was to be fair, we were able,
That's a great
fluoxetine
story.
was able to be used off-label. We were able to take care of it fairly quickly, but he was obviously very sensitive with that slight elevation. He didn't have actual breast tissue, but the sensitivity, the itchiness had definitely started. I'm one of them.
All the time.
Daily,
Every day.
hourly.
I think that kind of highlights one thing that I think is interesting in the controversy about hormone replacement therapy is that people that prescribe these hormones are often accused of over-medicalizing, like, this time in a woman's life. Like, oh, you're over-medicalizing, you're just trying to put women on these hormones. And it's like, no, we're actually trying to do the opposite, right? Like, women are put on antidepressants, they're put on all these on hypertensive medications, they're put on pre-diabetic medications, all because they've developed symptoms of hormone deficiency, right? And if, like, you address the primary problem, then you don't actually have to put women on all these other medications. So I think it just speaks to how the medical community just sort of reflexively gives women pills for whatever particular symptom they're having, rather than taking a step back and saying, wait, you're 45? Let's see what's going on with your hormones. Maybe that's the issue here.
The medical community tends to put a Band-Aid on those concerns specifically. And I know I get a special appreciation when patients come in with those exact symptoms of anxiety, depression, and they're on meds, and we balance their testosterone, and they're able to get off the meds. Because most people really don't want to take those meds, but it's the only thing that, for many of them, that gets them through the day. So when they find out it's a hormonal imbalance, and it's testosterone, it's easily managed, and it's safely managed, I think that's a great feeling that the patient as well as the physician has. No, absolutely not.
Not even a little bit.
No, menopause by definition is a day and time. That's when you have gone 1 year without having your menstrual cycle. So when women, and it's when we discuss menopause, we're talking about the symptoms associated with menopause, not the definition of menopause. So it absolutely does not end your sex life. The kids are gone. It's like a new world for a lot of folks. Yeah, especially once they get in our hands and we balance the hormones.
Yeah.
Yeah, and I mean, as a women, we kind of grow and we tend to know better what we want and how we want, the more mature we get. And it's unfortunate that in the middle of our active life, career-wise, sex-wise, suddenly we have that drop in the hormones that affects our sex drive and our orgasm. So I think it's also important to bring the hormones to help to continue live our best life. I do think that the best is yet to come. And as women get more mature, it's just another reason to have a better sex.
If we're doing it right, it's only going to get better. You hit the nail on the head. At that age, we know what we want. We know exactly what we want. Then if we have the support of our providers to make sure we get our hormones, our pelvic floor in check, we have the physical capabilities to match what our wants now, it's the best time in my opinion.
The freedom. I'll speak. There's a freedom that occurs with feeling successful. The kids are grown. If you're still married, you've worked through a lot of things, made it through. If you're no longer married, you have the opportunity to really explore your solo life. I call it solo more than single. So there's a freedom that comes with maturity. And women feel free also sexually to explore everything sexually. And they're open to it. And they're not smothered by the myths of religion and culture as to what sex should be or should not be.
They get more open and care less about what other people think or what society tells you.
Okay. And question is, do you personally take HRT or TRT or recommend it to family members? Why or why not?
Oh, yes. I was giving them a chance because obviously I do. Yes, I obviously do. And it's changed my life. As I said, my menopause was just horrible. So it was personal for me. And it was just very personal. I have stories of like mid-40s where I was in the middle of a fabulous party and I just came out with this. I thought I was too young for menopause, for hot flashes. And I just drooled down. I felt like I was standing in a puddle. But I was already had the answers. I just needed to make it through that night. And yes, life-changing for me.
Wow. Anyone else?
Hormone replacement therapy improved my relationship with my mother, who was miserable, and that it was affecting people around her. And I placed her on hormone replacement, and she's the happier camper over there, healthy. And she recommends her friends to also start hormone replacement therapy. And I think it's also very relatable when you can tell the patients, like, listen, if you would be my relative, I would definitely do that for you because I care about you.
Mm-hmm.
So I'm not a candidate at all at this point in time. When I am, I will be. But I put my husband on testosterone, and let me tell you, a lot more gets done around the house. No, I love HRT. Obviously, it's case by case dependent. Like my mom was one of those classic cases where we're going to throw, medications at you, where you have anxiety. She had Graves' disease. Of course, she has anxiety. So we finally said, hey, let's check things besides your TSH now. Let's, maybe we venture off of the levee. We look at a T4, T3. We go to Armor, and my mom is no longer on those medications. She feels incredible, but there were bone health concerns. And of course, in her case, given our gene testing, she's not a good candidate for all forms of HRT. But that doesn't mean HRT isn't a possibility. We do off-label, she's on SERMs, which are selective estrogen receptor modulators, to help as an agonist in her bone tissue. So she's getting that assistance through a variation of HRT, essentially, even though she's not a candidate for what we would conventionally see post-menopause. And she's a different person. It reverse aged her 20 years. It's incredible. So big fan of HRT.
That's great.
I think it's important to add here that it's never too late to start. And so some women think it's just because they don't have the hot flashes. Like it's never a day when I speak to women that the women in the room are like, oh, I'm menopause, I'm done, I'm too old for that. Because they are long-term, well-proven benefits. And every day, thank goodness, in the medical journals, there's another one, like the protection of your heart. You were speaking of the bones, which made me think of that, keeping your bones nice and long and strong, because the complications of osteoporosis are one of the major causes of deaths in a nursing home. Because so when women they fall, they break their hip fractures associated with immobilization. Once immobilization, urinary tract infection, pulmonary embolus, sepsis, and they're gone.
Yeah.
And so protection of your heart, bone, and Alzheimer's and dementia. Studies now show, and they show, and aren't you so excited that we're getting the journal, the feeds from Western medicine almost daily about, oh, look, we have this study. Well, we've been trying to tell you for a long time. So once women are informed of the long-term benefits, they're like, oh yeah, I think I'm going to get back on this. And I get a question often, is it too late to start? And it's never too late.
Yeah.
Got patients in their 80s, and they look like they're 60-something.
Yeah.
And they act like they're 50-something. So they get in a lot of trouble, which I love. Good trouble, right?
Josh, are you on TRT or anything?
I recently started dabbling in TRT because I am going to be 44 next month, and have just been feeling kind of low energy for a while. And I'd been tracking my numbers, and they were just starting to creep down. And it's been great. Like, I feel like I have more energy. I'm more motivated to do things. I think my mood is better. And so, but there was even as a prescriber of hormones, there was still like a hurdle that I had to like personally jump through, to like accept that it was like just time to start. But there's I think there was one study that showed that men that go through the medical education system, I think it was at residence or something, they tested their testosterone levels and they were like lower than like their counterparts that weren't in medicine. It's like these systems that we go through stress our bodies and stress our hormone levels. So it was bound to happen. But
How long have you been on it now?
About 6 months.
Okay.
Yeah.
What are you taking? What form?
I'm actually taking oral testosterone. Yeah.
Okay.
Yeah.
What made you choose the oral testosterone over
It's shorter acting. So I thought it was a nice like intro into testosterone replacement. It works for me. I'll probably switch to something else at some point, but I was like interested in trying it. And I take it in the morning, and then I take it like midday, and I get like a nice little, I was just really struggling at like 2-3 o'clock in the afternoon. And so now I'm just like, great, I can finish my day. And yeah. So it's been good.
And you're ready for happy hour now.
Exactly. Yeah. So.
Oh, I got it. So if women knew how important the G-spot is, and how G-spot enhancement aids in sexual pleasure because the G-spot is located right in the vagina, if you didn't know, ladies, right in the vagina, and it enhances the feeling of penetration. And so I think if women knew the value of the G-spot.
I think I have two. One, it sounds simple, but it's not simple. I wish women knew to retract their clitoral hood because there are so many women who have adhesions between clitoral hood and the clitoris, and it impacts the quality of like their sexual life. And for guys who is uncircumcised, it's normal to retract their foreskin. They have a strong erection, so the foreskin being retracted. But for women, our clitoral erection is not that strong. So I always recommend women, along other recommendations, to retract the clitoral hood at least daily when they're in the shower. That's one thing. And another thing that's not related to hormones, but in general to know how vaginal birth affect the pelvic health and sexual health. Because unfortunately, I believe there is like a great conspiracy theory that doctors do not tell women all the positive things about C-section and all negative things about vaginal birth. So a lot of women go out of having a baby traumatized, damaged, and they don't know where to go with that. And then we meet them when they like their 50s, when they're going through the menopause, and we're trying to fix everything else. And then we see that onset of all the sexual issues started after the vaginal birth, and women just needs to be informed.
Sex shouldn't hurt. There's that
part.
I can't say why. It might be inadequate lubrication, might be hormonal, might be pelvic floor dysfunction, could be lifelong disfigurements that you don't know is normal. But sex should not hurt. And if it hurts, you go see someone that can fix you.
I would say just if women knew more about their anatomy in general.
People.
That not, yes, their providers knew more about their anatomy. But, when women talk about issues that they're having in their genital tissue, it's always, my vagina hurts, my vagina doesn't lubricate. And then you examine them and you find out that the problem is actually on the vulva, or it's on their clitoris, or it's their vestibule, which is an area that no one examines. But those distinctions are very, very important, right? Because if the pathology is on the vulvar tissue, that treatment is going to be drastically different than if it's in their vestibule or if it's intravaginal. So I think we do a bad job of educating women on their body parts, both as like people and as providers, I think.
And that's not something covered in like our education system, like for children or like sex ed.
Don't get me started on our education.
I know my parents
system.
threw me a puberty book that had very graphic drawings, and I was like, whoa.
Yeah.
I'm 12, I don't want to see this, but I learned everything, and I learned proper verbiage as well. So I didn't appreciate it at the time. I appreciate it now, though.
Yeah.
And I think, again, you're absolutely right. When the babies like go to daycare, nobody names the organ. It's like all these weird names. So I think when we normalize it, when we talk to our children that this is penis and this is your clitoris, this is labia, and they know how to name those areas, same as they know where the arm, where the head, where the eyes, I think that's very helpful, and it actually removes a lot of issues that it can come later in life.
So what is the what's wrong with the sexual education system?
There is none.
Where do we start? Yeah. I think first of all, and this kind of tails off your point, is that sex education, I think, should start before high school. I mean, that's the first exposure that I had to it, and it was literally my PE coach was also our health teacher, and it was just like, this is how to not get pregnant, this is how to not get sexually transmitted infections. It had nothing to do with anatomy, it had nothing to do with pleasure. God forbid we should have sex to feel good. And at that point I was already like 15, right? Like, I think it should start when the kids are small, talking to them about their body parts, normalizing these parts of their body so that they don't grow to be a 15-year-old who's like really insecure and shy and doesn't want to talk about this and doesn't pay attention. And so you have all these, adolescents moving away from home, going to college, and like, they don't even know how to have sex, right? And if they do, it's certainly not about pleasure for both partners, right? Like it's just It's a shame. I think we need to start younger.
Well, sex education should start with their parents.
Yeah.
Because and parents should normalize conversations when kids are like 12, 13, 14. And you just bring up topics, you just start talking about things so your children will be free to come in to speak with you.
We use movies as a caveat in my household. As we bring them up, it becomes a transition piece, and now my kids hate movies with us. But
It's a good idea.
I think being a high-achieving woman comes at a cost maybe potentially to mental health, which obviously has a huge impact. And again, we look at things like even just cortisol or adrenal dysfunction in any capacity. That's going to be a trickle downhill effect, essentially. I think anyone that puts themselves in a high-stress situation, like what you brought up in terms of statistics and seeing those declining levels, I mean, yeah, I think anyone that's high-achieving is going to be subject to more down-regulations than the average person.
I think in general, women's sexual health, sexual response cycle is different from men. So for men, their predominant type of desire is spontaneous desire, where they see the object of interest, they want to have sex, they have erection. Sorry for making it so primitive.
That's pretty much how it happens. Pretty much how it goes. Yeah.
For women, it's a little different. We have spontaneous desire and we have responsive desire. So sometimes in order to be interested in sexual activity, the object of our interest needs to initiate, and it can be anything. It can be flowers, it can be dinner, it can be a nice ring or kiss on a cheek, whatever it is. And as we're going through that beginning stages of relationship, we might get interested in being sexually active. And it's very normal. Majority of women have responsive desire, so nothing wrong with that. The other issue arises when high achieving, it's also very broad term, meaning are you high achieving, you have a great career, or you have 5 children at home who you're taking care of. There's a lot of things go into that. But all of those things, they take your attention away from you, from your sexual relationship in some sort of way. So I think in that settings, you do need to have a really good partner who can take some of those responsibilities from you, like kind of unload your head so you can get that space for being sexual, being interested and experience the better pleasure.
I think simply put, it's about time and priority.
Absolutely.
I think hormones get the blame a lot for it, and yes, hormones do play a role, but I think it's only a small factor of the equation, like especially, and this is not my realm at all, but when you look into like the neuroscience aspects and the studies where we look at men and how a visual stimulus will affect a male versus how it affects the female, and it activates certain like neural pathways. The reason we see more prevalence in like porn-induced erectile dysfunction among males versus females, I think a lot of it's just innate wiring that is out of our control and response. Doesn't mean we can't enjoy it the same, but I think that initial desire is going to be neurological differences.
So why do women report feeling too tired for intimacy more than men?
Because we are.
Because they're exhausted. It's not a priority. And it requires, I think we've all said this, requires just a lot more for a woman to relax and become sexual and feel sexual. It's not so spontaneous, especially when you have the weight of, you have 5 of the jobs going.
Is it men's fault, or do men need to be playing a bigger role to allow their partner to relax?
I think there just needs to be more conversation and communication.
That's
about
exactly
the
what a
differences.
relationship is, too. That level of communication between partners.
So a couple has to really set aside the time for the relationship because it requires time, energy, and effort. And we have very little of that. So we have to make that more of a priority.
Yeah. And also relationship, the way how you have sex as a couple changes when you were just dating, when you just get married, when you have a kid, when you have a few kids. So the priority changes and the way how you can get that time in changes.
So here's a direct quote from someone, and I'd like your guys' opinion on this.
Where are these people coming from?
The internet.
Oh, great.
Okay.
Like forums,
Great.
Who are these
online.
people?
Awesome. Yeah.
Reddit.
Yeah.
Pretty much. So night sweats, mood changes, hair loss, sleep changes, period changes, skin changes, always cold, always irritated, can no longer process alcohol, sugar, or bullshit. Oh, and as a bonus, I stink all the time. Different areas of my body, I shower at least 6-7 times a week. I stink and I don't like it. This is someone going through menopause.
She needs a boyfriend.
Yeah.
Yeah.
They need hormone evaluation. There are multifactorial issues going on.
Peri's a rough time.
Yeah.
I think people just assume like, oh, menopause is terrible because your hormones are so low. No, peri is when you are on a roller coaster. You feel it, your spouse feels it, kids feel it, we all feel it.
Yeah.
It is not a fun time.
Yeah, I think even as a provider, treating perimenopause is so much more difficult than treating women that are just in menopause already, because of those fluctuations.
And hard to identify to a lot of people, especially, again, the primary cares that haven't had that extended education. They'll pull maybe FSH. They're not looking at LH, FSH, AMH. They're not actually pulling at different times to look at estradiol fluctuation. So it's kind of hard to pinpoint and then get the referral to you guys as well.
And they're certainly not drawing testosterone.
No, never. You don't need to do that if you're a woman, right?
We have another story here. It says this. At 42, I began experiencing major executive dysfunction, tinnitus, night sweats, fatigue, brain fog, panic attacks, existential dread, and suicidal ideation. My depression and anxiety worsened, accompanied by disassociation and paranoia, especially in the 2 weeks leading up to my period. I haven't been able to work in 6 months, but with the help of various medications and hormone replacement therapy, my anxiety has significantly decreased. Why is this person, like, their symptoms seem a lot more crazy than average, talking about panic attacks and suicidal ideation? What is that? Is that related to their hormones as well?
Well, that's a great question because that's my world. So I think when I tell some of my perimenopausal ladies, some of the ladies just come in because they have a difficulty time losing weight or just sleep. So it's a spectrum of symptoms. And thank God most people are not on the bitter end. Most people are somewhere in the middle-ish and whatever. So a lot of patients come in to see me because they're eating the same, working out the same, and they're not losing weight. And the other issue that they're coming in for me simply is sleep. So I think it's a misnomer. We know it, but maybe for the public, that you have to have the full spectrum of symptoms before someone listens to you, and they have to include hot flashes. Because hot flashes, the symptoms in my experience are really temporary. Usually 47 to 51, they knock my door down, and then somewhere mid-50s, they sort of dissipate. And except for the unfortunate women who are still getting them in their 60s, but there are just so many symptoms associated with menopause, and then there's a spectrum of what women experience. That's why hormone balancing is very individually managed for that patient, and also for that patient during her lifetime. So I think the story that you just shared with us sort of really exemplifies that. Someone on the extreme.
This particular story makes me think that there might be a progesterone issue. Progesterone, in my experience with perimenopausal patients, is one of the first hormones to just sort of bottom out. I mean, of course, testosterone, like, we always look at that too, but a lot of these anxiety symptoms, these changes in libido, changes in cognitive function, mental health stuff, sleep, right? That's a lot of times because of a progesterone deficiency. And so that's one of the first things that I'll put someone on when they come to me with these kinds of symptoms. Because a lot of times you'll check their estrogen, and that's kind of all over the place, right? It's like a moving target, but we'll measure throughout the cycle, and it's consistently low.
The next one is talking about Halle Berry's perimenopause journey. I have a little quote here. Halle Berry candidly shared her struggles with perimenopause and its impact on her sex life, experiencing vaginal dryness, a common symptom of perimenopause, which made sex feel painful, likening it to razor blades. If you guys are familiar with her story,
yes.
If you have any comments or any takeaways from her sharing about her journey, what would it be?
Yeah, that's a day in the life of my practice too. One of these symptoms women experience throughout the years, the 45s to the 70s, is really vaginal dryness and difficult and painful sex. I think what we find is doctors don't ask the question. So finally, the marriage they're chatting with someone, and finally, like, why don't you go see her and she can help? But I run across many patients that no one has really asked about sex, intercourse, sexual dysfunction. And at the time of the annual exam, that really should be a question. Yeah. And then women can be referred, because there are a lot of options, from just topical oil to vaginal estrogen, etc.
Well, the story, as far as I remember hearing about this in the press, was that she was actually brave enough to bring this up to her provider, right? And so the takeaway that I had from it was, like, you have to believe women. You have to listen to women when they're telling you something and not just reflexively think, oh, I believe that she was diagnosed with herpes incorrectly, right?
Correct.
Because she was saying it's dry and I have pain when I have sex.
That was her original diagnosis?
Yes. So her provider said, oh, you must have genital herpes, put her on herpes medication. And it wasn't until she saw someone else who was like, well, actually, no, you're in perimenopause and you need hormones.
Her labor was raw.
Yeah. And she had to then talk to her partner at the time. And, that's a whole sort of coming out that you have to tell your partner, oh, I was just diagnosed with herpes, but then those tests came back negative. So it's a very traumatic thing when you don't believe what someone is telling you and really understand that they're at this point in their life and there's a good explanation for why they're having the symptoms that is not herpes.
So I didn't know her story. Apparently, I live under a rock. But I think it's fantastic that we have people that are in the spotlight and celebrities that are speaking about this and normalizing it. And so many women don't even necessarily know how to communicate with their providers. And then when they do, they have situations like that. But I tell a lot of women, if I say, well, do you have any vaginal discomfort or dryness? They're going to think, well, am I 80? Do I have cobwebs? And I'm like, no, it can feel like you have a chronic wedgie all day. It could be some slight itching. It could be slight discomfort during intercourse, which in turn can almost become a libido issue because, they're programmed at that point. They know that they're expecting pain. They might not realize it. But I think that's fantastic. We have celebrities speaking about the uncomfortable conversations that shouldn't be.
Cacophony of voices every day. Cover up all the magazines that women read. So I'm so excited about that because women do call and they're talking about it and they come in because like, wow, okay, I'm having this too.
Adequate progesterone levels,
That's
growth
what
hormones.
I was going to say.
Testosterone.
Yeah.
Yeah, testosterone makes a difference in progesterone. It's amazing how many women, especially in the perimenopausal area, when you necessarily don't need progesterone because, you don't have to supplement the estrogen to protect the lining of the uterus and they're still not sleeping. You just add the progesterone and it's just like, oh, thank you, this is wonderful.
Yeah.
So is sleep different for men than women?
Progesterone has a lot of influence. I think with women, especially because of the fluctuations, because of our menstrual cycle, we're going to be more susceptible to those changes in sleep disruption, especially when it starts to drop. And unlike other hormones, we tend to see progesterone decline fairly young. It's usually going to be far before perimenopausal states. And it is life-changing. So many women, and I'm hypothyroid or I'm deficient. No, you just aren't sleeping. You just need a little progesterone. It'll take care of everything. It's incredible.
Well, how can women naturally, if they're in their 20s, get more progesterone so that they can sleep better?
Again, this kind of goes back to underlying conditions, birth controls, things that we discussed earlier. But one of the big things, everybody wants a natural approach, but pharmaceuticals exist for a reason. We have them. And my biggest thing, wild yam cream does not work. It is a scam. Diosgenin is required. It requires synthetic solvents and catalysts. Your body's not a laboratory. It cannot it cannot scientifically convert to other sex hormones. So women should not waste their money on wild yam cream, no matter how good the TikTok influencers tell you it is.
What do you guys think about that?
I like the taste of yams.
They do make creams out of diosgenin. That happens in a laboratory where there are catalysts, but you can't just smear wild yam cream. And I never thought, it changed my life. And perimenopause isn't forever. At some point, symptoms usually do subside, and I'm all about a powerful placebo effect.
I think what this brings up for me is, like you said, we have pharmaceuticals for a reason, right? And certain things happen in your life where you no longer make the hormone that your body needs. So thankfully, we have treatment options. I get patients all the time that come in and say, what can I do naturally? And sometimes I'll give them homework. I'm like, all right, you want it, for 3 months, I want you to get 7 to 8 hours of sleep. Good luck with that without progesterone. Exercise 3 to 4 times a week. Good luck with that with the family and kids to worry about. Make sure you're eating a well-balanced diet. Give patients homework and they come back in 3 months and they're like, I really tried doing all those things you did, but I'm still struggling with X, Y, and Z. And I'm like, okay, well now we're going to add these things. You should do these things in conjunction with a healthy lifestyle, right? These are also not magical treatments that are going to fix all of your problems. But I think just suggesting to someone that they can cure their perimenopause with, natural remedies is a little bit harmful.
What about for let's say women who aren't going through perimenopause, but maybe have other hormonal issues or thyroid, birth control, all these things you said, is there anything they can do aside from hormone treatment to, balance themselves out, I guess?
Oh, absolutely. It's my world. So there are supplements that you can purchase at your retail pharmacy. Black cohosh seems to work well. And they're primrose oil. You can take soy if you choose. But the only thing is most of those supplements and hormones associated are developed to help hot flashes and not the hot flashes and night sweats and not the symptoms that are associated with low testosterone. Fortunately, there are a couple of prescription or prescribed pharmaceuticals now that help women with hot flashes. Venoza, Venoah, and but they help by soothing and relaxing the system that causes the hot flashes. So there are ways that women can help alleviate some of the symptoms of menopause without taking hormones. Because in my practice, I have women who've had breast cancer, estrogen dependent breast cancer. So we often have to give them those options so they can feel better.
And do women need more sleep than men?
I think it's unique to the person, not necessarily gender specific.
Yes.
And obviously there's certain times in our life where we're going to require more sleep and recovery than the average person. I'm not sure if that's gender specific though.
Okay. Should women fast differently than men?
Fast?
Yeah, fasting, intermittent fasting.
I'm not a big fan of fasting in general. It's if it works for you and you lose body weight, then that's wonderful. But again, working with the physique enhancement side of things, I mean, a calorie deficit's a calorie deficit. You're going to lose body fat or you're not. But I think by giving yourself a very short window of time to eat, male or female, and adding that degree of restriction is going to limit your micronutrient intake. It's probably going to affect well-balanced macronutrients. And as an end result, and this is not a general rule, I'm not saying it happens to everyone, but it can really help you develop a poor relationship with food and lead to binge-like behaviors because you usually don't choose the most nutrient-dense, optimal choices when you give yourself a restricted window of eating. And yes, if you fast, it works. I get it. I get it.
Do you guys have any other general thoughts on fasting in general?
I'm not a proponent.
I don't know enough about it, actually.
I'm against snacking. I grew up in Russia. We do not snack. We have breakfast, lunch, and dinner, and there is no food in between. So when I moved to the United States, I was surprised about snacking. So whoever talks about like fasting, I'm doing a fasting diet. I'm like, meaning you eat normally, breakfast, lunch, and dinner? So yeah, I believe in 3 meals a day.
I eat like 7 meals a day. Yeah. So.
Let's talk about magnesium. Is that a real miracle supplement for women?
I love magnesium supplementation.
Why?
Most people are not. I mean, I'd say most people are on lower ends of magnesium. I think it's has therapeutic properties as well. Day-to-day stress management, sleep. Obviously, there's certain types of magnesium we would like to implement, but I think it improves overall quality of life, helps with sleep pattern regulation because I try and avoid melatonin if I can. I'm a big fan of magnesium, and then of course we see other improvements in health markers as long as we're addressing any deficiencies. Zinc and magnesium especially, I feel like a lot of people end up deficient in.
Why do you avoid melatonin?
So melatonin can actually, it has some degree of influence through sex hormones as well. I actually use low-dose melatonin on myself to improve my testosterone levels because I can't take TRT. I want to. So I do very low dose, like 10 milligrams of DHEA. And obviously in terms of preferred metabolic pathways, I'm not converting a lot to estradiol. Everything takes the androgen pathways for me. But I do that with low-dose melatonin. I do aggressive omega fatty acids, and then I make sure I keep my vitamin D levels pretty high.
Well, what could be is there an issue with melatonin? Or
so, like, people like to give it to their children. And again, just because we know it can influence other hormones in the body, I'm not a huge proponent of it. Now, I'm using it as an adult for that purpose, but because it's utilized haphazardly like a Flintstone gummy, I prefer not to see it utilized in people unless they're aware of what's going on with their adrenals already. AOD 9604.
Ooh, what's that?
Anti-obesity drug. When we see like the popularity with like the growth hormone releasing hormones, growth hormone releasing peptides, this is a little bit different. Like HGH frags are different because they don't influence the pituitary, so they're not increasing endogenous production of growth hormone, so it doesn't influence IGF levels. But when you can isolate those effects for fat loss, everybody says, that means I'm not messing with my hormones, no water retention, I'm going to spot reduce my fat, I'm going to have no abdominal fat. And well, the reason you're seeing this anecdotally is because the people that are taking performance-enhancing drugs are now moving, lifting weights, and eating in a calorie deficit. And funny, if you remove the AOD, it does the exact same thing. We have very loose clinical data showing the promotion of lipolysis in our rodent models. That's it. It's probably, I speak out against this peptide more than anything, and it is everybody loves it. They beg their providers for it. I think there's only a couple major compounding pharmacies that actually carry it. It got moved back from the Cat 2 list last
What's your
November.
favorite peptide?
Yeah, like straight up growth hormone, honestly.
Okay.
I'm a big fan of tesamorelin, though.
Yeah.
Do you guys offer Tessa at your practices?
No.
I've taken tesamorelin, and let me tell you, my waist, because the clinical application is in HIV patients for reductions in visceral fat.
yeah.
The issue, though, in a performance-enhancing context is people don't take them with the GHRP, so they don't get the full effects, and they don't take it at a clinical dosage. They'll take it at a fraction because of the price, but you want results, things come at a cost. So when you run it at the clinical dosages as a non-HIV patient, it tightens up that waistline. You get all of the enhanced therapeutic benefits of growth hormone with reduced side effects. Not a big of influence on your blood glucose levels. You're not going to see that A1C trend up. You cycle it 8 to 12 weeks. Great sleep. You sleep like the dead. Skin, hair, nails. Problem is it has to be cycled though, so you can't stay on it forever.
What do you guys think? Are there, when it comes to GLP or things like Ozempic, what are your thoughts on that? Is it?
We love it in our practice. We love it. I have lots of A-list actresses that are on it. I find, fortunately, when they're on it for a few months, it then decreases their satiety. So, which means, I mean, they become full earlier, so they have satiety. So I think the aha moment is like, oh my God, I didn't realize I needed to eat so much. I didn't need to eat so little food. I'm not hungry. So I think in a lot of my patients, it carries on. So I think there are concerns I see in the literature about, or, the stories about the sagging skin or whatever. We don't see it. They lose 40 pounds, and majority of my patients were on it and no longer on it. So we do it short term with hormone therapy, but not long term.
Okay.
My concern with GLP-1s is it's a newer drug. There is still so much that we don't know, the consequences of that, and especially in terms of sexual medicine, and I'm sure, Joshua, you can also speak on that, that there are more and more case reports coming up that the people who took GLP medications, they noticed decreased libido, decreased quality of orgasm. And it's not for, not everyone, but now there is more and more data about it. So I think we need to do more research. And I'm just very careful with people who already having issues with sexual function to add the GLP medications.
I think when retatrutide comes to market, sema and tirzepatide will pretty much be obsolete. I think a lot of it comes with patient-provider communication and relationship too. If we can really reduce rate of loss, even just 1% of total body weight, I think we see a lot less hormonal downregulations and decreased quality of life. But it's so exciting to take that shot once a week and watch the weight fall off that you've been trying to lose your whole life. But again, this always circles back to kind of blood work and provider input. Are we doing labs to assess for underlying causes before we utilize it? And for some people, it's just great for appetite management. So simple as that. And I always tell people, it's not to quiet your food noise and get rid of it. You need food noise. We have taste buds for a reason. It's a survival mechanism. You should walk by a plate of cookies and want a cookie. Now, it gives you the ability to say, no, I've got goals. I'm not going to eat that cookie. But you should want cookies when you walk by them.
And we offer many types of weight loss. We have many regimens in our practice, and I always let them know that they really are not going to see maximum results unless their testosterone's balanced. So the majority of our patients who are on Ozempic are also on, well, all of them are on hormone balancing too. So they're getting
lean tissue as well.
testosterone.
Yeah.
And then we work with nutrition so that we don't just give them the Ozempic and just let them go. We give them a full nutrition. We give them options, give them suggestions of what they should eat, and then balance the testosterone, and we get great results.
Okay, last question. Is there any common medical advice that makes your skin crawl, like you just hate hearing it? A trend or medical advice that you're just like, that is bullshit?
Yeah, one, hormones, don't take those. They'll kill you.
Hormones cause cancer.
Yeah, hormones cause, for many reasons, don't take those.
Probiotics. Everyone overtaking probiotics, like tons and tons of probiotics. And then they come in and saying, I feel bloated. Yes, because you took so many probiotics. And then if there is anything going on with vaginal health, take probiotics. But we forget that everything needs to be in moderation. So probiotics is one of them, and another one is drink as much water as you can. And as a urogynecologist, I mean, thank you, water bottle companies, for bringing me those patients. But people forget that the more you drink, the more you pee. And then they come in and they complain about peeing at night all the time, going to the bathroom all the time, trying to do things. You don't really need to drink that much water as we hear commonly. Like, you should always seep that water out of your huge glass. So everything in moderation.
What would be the right amount of probiotics to take?
Well, there is a reason why you're taking them, right? If you just been on like a long-term antibiotics, yes, you should probably take probiotics, or you can take a food that enhances your own, growth of your own bacteria. If you want to take something as basically health maintenance, once a week should be plenty, not daily or 3 times a day.
And how much water should we be drinking daily?
You should look at your pee. If you pee, he just has a colored drink in his cup. Normal urine should look like a straw-colored, clear fluid, right? If it looks darker, then you should drink a little more. If it looks almost like water, you should definitely cut back on your fluid intake. And normal in animal kingdom, there is no giraffe or antelope that keeps drinking. They drink when they're thirsty. So, and it's also, we need to remember that we do need to drink when we're thirsty, not only when we overdoing it.
I don't think I have I'm not a provider, so I can't talk about the horrible things that we need to listen to in terms of advice. But what I can say is, don't be afraid to ask for a referral or a second opinion when you hear your labs are normal. In fact, if you hear your labs are normal and that's the only thing they say about your labs, get that second opinion anyways.
Yeah. I was going to say that the HRT, TRT causing cancer, as I mentioned earlier, I see both men and women. And there obviously is a lot of attention paid towards the Women's Health Initiative and all these concerns about HRT causing breast cancer, endometrial cancer, all these sorts of things. But there's been a parallel story with men and testosterone replacement therapy. And there's this old way of thinking amongst the urology community that testosterone causes prostate cancer, or that if you have prostate cancer and you are on testosterone, you have to be taken off of it. That is not true. The data, good quality data that we have, shows no link between testosterone replacement therapy and prostate cancer. And there have been studies that have actually put men who have had prostate cancer treated back, who are hypogonadal, back on testosterone replacement therapy, and they have no increased incidence of recurrence of that cancer. So it's interesting that there's these sort of parallel stories happening in men and women about, and it's all kind of fear mongering, right? It's all, which is silly, because it's why are we making people scared of these hormones that their bodies need? And so I would say that's the most annoying thing that I encounter.
I wish they would pay attention to their erections. You probably deal with this a lot. If you, at the peak of your sexual health, as a hormones raging 18-year-old, woke up with a solid morning erection, every single day and didn't have those libido issues, you should still be aiming to achieve regular erections with good quality erections beyond the age of 25, 30, 35. And when I speak to men, especially regarding ED issues, they don't actually track. And now I don't have a penis, so I feel like if I had one, I would be very aware of what it looked like every morning. But as I'm sure you know, especially, a lot of men are not tracking that. They can't tell you how often, how regular, quality. They're not paying attention to it. I know I would, but
I think for me, it's that that there is a natural that losing your ability to get an erection or having problems achieving ejaculation is a natural part of getting older. And that age, that you have to be of a certain age to have a specific kind of sexual health problem, right? So like I see guys in their 20s who have erectile dysfunction. Sometimes it's not psychological. Like sometimes we do a full assessment. They have hormonal issues, they have blood flow issues, but often are written off because they're 25, right? Same with things like delayed ejaculation or premature ejaculation. Everyone thinks like, oh, premature ejaculation only happens to young guys. No, it actually can happen at any point in your life. You can have a totally normal ability to ejaculate, and then something changes, and you sort of lose that ability to control your ejaculatory time. So I think the relationship between sexual dysfunction and age, getting men to understand that it can happen at any point in your life. It's not normal. It's more common as we get older for a variety of reasons. The effects on the cardiovascular system, our hormonal, imbalances and deficiencies that come up as we get older. But it doesn't mean that you have to like resign yourself to existing 30, 40 years without being able to have like satisfying sex. I'm Dr. Joshua Gonzalez. I'm a urologist and sexual health expert, and you can find me on most social media platforms at Joshua Gonzalez, MD.
I'm Alexandra Dubinska. I'm a urogynecologist, pelvic floor reconstructive surgeon, sexual and menopausal expert. I practice in Beverly Hills, California. You can find me on Instagram at Dr. Urogyne or on YouTube at Dr. Urogyne.
I am Gail Jackson. I'm a gynecologist, and I practice in West LA. And you can find me at drgailjackson.com. And I have a new book, Amazon bestseller, called Absolutely Fabulous, and it'll help you navigate menopause after 40.
And I'm DJ Madsen. I own M&M Health Solutions. If you need blood work or your provider is unable to pull hormones, or maybe you don't have insurance coverage, we work with HSA and FSA as well. You can find us at mnmlabs.com, M&M. And I'm Coach DJ Vanilla Face on Instagram, TikTok, and YouTube.
Great job, guys. Wow.
That's a wrap.